All right, thank you very much, Joan, for sharing that, what appears to be truly youth participatory intervention and pilot. So we are now in the discussion section, and I would like to ask if there are any questions or comments that we would need to address. And please address whichever speaker you'd like to answer, or if it's general, you can just say general. So we have Millicent's hand was up here, and then two individuals here as well who have a question too. Yeah.
Okay.
Any others? Three. Hold on. I'm sorry. My seatmates are giving me pressure up here. And then we'll have Natella and Allison as well. Allison, okay. All right, let's do that round, and then if there are others, then we can address them as well. So please go ahead. Millicent had a hand.
Okay.
Yeah.
My name is Millicent Atujina. I'm from the Desmond Tutu Health Foundation. And thanks to all the presenters for the wonderful talks. My question is actually to Lindsey. I'm very much interested in the community-based testers. And I wondered whether you can tell us more about how these community-based testers were selected, how they were trained, were there any challenges that were experienced? I mean, this looks like something that is scalable, but probably a little bit more about that. Thank you.
Thanks for the question. The community health workers are extensively trained in everything from HIV work, TB screening. They do a lot of vaccine implementation throughout the community. So they're members from the communities that they're living in and trained for health work. The specific campaign included not only just HIV testing, but we kind of tried to package it with other services to really kind of further destigmatize HIV testing, and added STI testing, TB screening, pregnancy testing. So they're trained kind of in a range of clinical services. And then they, upon testing, the participants would be walked back to the clinic and linked to counselors, psychosocial support from people trained at the clinic. I hope that kind of answers your question.
Yes, Tim.
Hello? Yeah, so thank you all for such wonderful presentations and insights on the research findings. I'm Agatha Bula. I work with the University of North Carolina in Malawi. My question goes to Cindy. You talked of one side of the dance study being closed because of ethical issues. I'm just interested to know what were these issues, because we have so many issues, we have so many challenges to involve adolescents into these studies. And then the last presenter on the use of mobile phones to promote access to care. I'm also interested to know whether you have plans to add on the issue of like how the mobile phones interaction can help to deal with mental health issues among these adolescents, because that's one of the issues that has come out in several presentations. Thank you.
Thank you for your question. The one center that was closed did have some issues with their local ethics committee. And so I'm sure you're aware each hospital has their own ethics committee, and they manage the participation of the site, their staff, with regards to the study. And they noted some inconsistencies in the way that the study was, the study site team was performing different pieces of information, and how they were collecting information and how they were performing their duties during the trial. So.
Then I believe Aoife has a question to you.
Thanks for the question. I think there's There's definitely a huge potential. I guess there's information and sort of building literacy, like was discussed earlier. But then in terms of treatment, I guess there's also a potential. I think, at least in the context that we work in, the issue of how to manage the technology is a major one. But I think I see promise, but of course you have to tread carefully because of issues around confidentiality. But on the flip side, the capacity to scale up is potentially huge, if you can get the tech and the access correct. So it may be that there is a way to do it in a more fixed way where young people can come to a setting where there is Wi-Fi or there is some access. And I'm sure some people here have experience of doing something like that. Yeah.
Thank you. And Nico, you had a question?
Yeah, sorry. It's not a question, it's just a comment for Ms. Joan from Tanzania. I think she tapped on Pete's dolutegravir on the last slide. I just wanted to raise awareness around that we should consider including caregivers whenever we want to promote pediatric dolutegravir. And just to give an update, I think here in South Africa, the formulations were introduced, I think, recently in September. And then we're looking forward to having the drug around December. Pete's dolutegravir. Thank you.
Thank you, Nico. And then, so, number 3.
I'm Nandipa Jacobs from Health Systems Trust, Durban, South Africa. My question is to Joan. I was just interested in some of your retention rates for your participants based on the suppression rates that you've seen. And then my next question is to Lindsey on your community testers. Were they initiated in the community on treatment, or did they have to go to facilities? And did they self-refer to facilities if they were initiated at facilities?
Thank you so much for the question about retention. But unfortunately, in this cross-sectional analysis, we only looked at the viral suppression at a snapshot, and we didn't really look at retention at different time points as much as it is defined at different time points. So maybe we look, I think I take it as a comment. We can consider it because we have the data. We can analyze and see what were the retention for different categories of the young population. Thank you.
The community testers all just did testing in the community, and upon positive tests, they were walked back to the clinic to do ART initiation at the clinic. They did confirmatory testing and then initiation at the clinic.
So, up front, questions?
Yes, so thank you all the presenters, those were fantastic. I had 2 questions, one for Joan and then follow up to Cindy. So Joan, as the resistance testing capacity gets lower, I do worry about between the 200 and 1,000 and what's happening in terms of evolution of viral resistance, and wondered if there's any subsequent plans to do any sort of deeper dive in terms of lower resistance testing. So that's one, testing at lower levels. I'll let you take that one first.
Okay. Thank you so much for your question. So regarding the thresholds for genotyping that was used in this national surveillance, the bar was the 1,000, yeah. But I'm aware that there's the issue of a low level viremia at different thresholds, and so far in the country we can't perform the NGS, the next generation sequencing, that will really cater for the thresholds of 200 or 400. And less than 1,000. But with this data set, I did try to look at the low-level viremia and look at, there was quite minimal data of previous records of the viral loads that were tested. So it's a matter of either documentation or missing data for the previous viral loads. Yeah, thank you.
And then Cindy, that goes to your question, my question for you. I think as an adolescent provider, I've had a lot of angst about the 2 drug regimens, and I'm just curious what you think, or which is the ideal, in air quotes, population of youth that DTG 3TC may be targeted for, given Joan's data, as well as even though the numbers were not terrible, but the viral suppression was within a clinical trial, I think, was a bit concerning, right? So just curious what you think as we target, particularly ART naive adolescents, who would be your target population that you'd be looking for?
Sure, that's a great question. So I wish I could describe to you each patient that would have a great clinical outcome. I think we've talked today already about a number of barriers to a successful treatment course for a patient. And so good support, I would say, is the best option for keeping a patient on study. Now that aside, and only looking at our study data from DANCE, again, we have a very small patient population, but our patients were recruited in areas of high HIV burden among adolescents. And what we did identify in our study is that most of our patients were newly identified as being HIV positive. And they, again, were receiving their first treatment, and we saw rapid viral load suppression. And again, rapid viral load suppression and that maintained support we have seen are coupled with a very good outcome. The cases where we did not see viral load suppression in our study were two that had elevated RNAs greater than 50, one at 56 copies and one at greater than 400, and 400,000. And the patient with greater than 400,000 was a patient that was struggling with adherence, and they did have an inconsistent support system at home.
Thank you for your answer. Number 3.
Thank you. My name is Judith Kose from the Elizabeth Glaser Pediatric AIDS Foundation, and I want to thank the presenters for very wonderful abstracts. I had a question for you, Lindsey, and I think from your abstract you mentioned that those who are tested in the community are likely to have poor retention and perhaps even other poorer treatment outcomes. And as you know, as we get to the last mile, we are doing more and more of community testing, index testing in the community, HIV self-testing in the community. So from your experience and from the qualitative data, what practical guidance would you give to national programs to improve the community testing? Because we are going there, we're not coming back to the facility. So what for you are the perhaps top 2-3 things that national programs must put in place as they implement community testing? Thank you.
Thanks, that's a wonderful question. I think, one of the, as you say, all of our services are trying to bring out into the community, and I think there's wonderful benefits to that. I think our study kind of shows that we can't just replicate everything that has worked in an adult population and an adolescent population, as we know. So if we're bringing out community testing through mobile testing, through door-to-door, to be adding a whole host of other support services if we're targeting adolescents and young adults, perhaps bringing peer counselors with the community testers, figuring out how to do much closer, immediate follow-up for those that are being identified in the community. So I think it really is just a matter of bolstering and bringing much more social, psychosocial support to these populations, because they certainly may see the benefit, as many other populations do, of bringing these services out into the community, and we want them to respond the same and long-term outcomes to mirror those in adult populations.
Thank you. So one last question, number 2.
Okay, good day again. I go by the name of RT. So I wanted to ask a question on the last presentation, because I could see mobile phone interventions and everything like that. So whenever we want to do after-school programs for boys and girls, like, how easy is it do you provide cell phones or tablets or data for the participants? Because others, they can't afford data, others, they don't have phones and things like that. So how did you attract those participants whenever you're doing mobile phone interventions? Like, I really like that, because I think it can grasp them and bring them closer and everything like that. Yeah.
Thanks, a very good question. So we did provide phones and we provided data. So it was small, it was a research study. As you know, in research we have a lot greater good restrictions on what we can do because it's still experimental. So we did provide phones. I guess you would not do that at scale, but it was testing almost the concept of like, is this even a good idea to do? Which it seems from the initial evidence we have that yes, this creates a safe space for young people to discuss. And I guess that's why I was saying like, okay, to take it further and to scale it up, how can we make this accessible to more young people? Because provision of phones and data is not possible. But we did, I mean, as a sort of small study, we gave phones, we gave data, we got the phones back. The phones were locked to that particular app, so there was not much abuse of the phones or anything. So, and the young people appreciated it, and we're sad to give the phones back, but gave them back. Yeah.
Thank you. So I'm going to end this session, and just to state that the abstracts, the presentations took us through testing, where testing is done, and how you enter the HIV program makes a difference. And we've had some of that experience in Nigeria as well as in terms of treatment. Do two drugs work as well as 3 drugs? And how does that translate into convenient dosing for adolescents? And then also talking about youth participatory interventions and piloting, and then understanding what youths need by actually engaging and involving youths in the decision making and in presentation to the larger ministries of health and policymakers. So thank you all for your questions, and definitely thank you to all the presenters for their excellent work. Thank you. We're going to have the group photo downstairs. So please make sure you are represented by being there yourself. And so let's all move downstairs. And then after that would be the fun times of lunch. We come back here at 2:30 sharp. No African time, please. 2:30.